Thank you, Mary, and welcome everybody. We are here for the Richard Behrman Endowed Lectureship in Pediatrics, which was established to honor Dr. Richard Dick Behrman's service and leadership at Lucile Packard Children's Hospital and on behalf of children's health worldwide. Dick passed away in 2020, but many listening and here today remember well his many contributions to our institution, chairing both the boards at Packard Children's Hospital and the Lucile Packard Foundation for Children's Health. Dick was both a physician and a lawyer and was always committed to health equity, human rights, and to intense cross-disciplinary collaboration, commitments that lay at the core of his many important contributions to pediatrics and his devotion to training what became to be many generations of pediatricians and others devoted to the health and well-being of children in the United States and around the world. We think he would have been delighted to know that Dr. Susan Kressly is the Behrman Lecturer this year. Dr. Sue Kressly is a general pediatrician and a clinical informaticist whose clinical career includes founding and growing an independent practice in Pennsylvania. She's been at the forefront of innovation, advocating for pediatric functionality in health information technology, and her expertise spans quality improvement, healthcare financing and payment, practice management, and optimization of clinical workflows. Dr. Kressly has served key leadership roles at the American Academy of Pediatrics with a focus on practice transformation, payer advocacy, pediatric health IT and quality care, and she currently serves as president-elect for the Academy and assumes that presidency role in January of 2025. Sue believes that all children deserve access to well-coordinated, patient-centered medical homes, which maximize the use of health IT, and she understands that every pediatrician is a child health expert, an advocate, and a healer, and she champions the voices of children and pediatricians wherever she goes. I know you'll all enjoy welcoming Dr. Kressly here today. Thank you, Dr. Kressly.
Thanks so much, and what a pleasure and an honor is to be here. Hi to everybody at home. Hopefully you're still not in your pajamas, but if you are, I hope you're comfortable. And I hope to at least distract everyone from that other thing that's happening across the country today, so that you have something else to think about other than what's happening. So I'm going to talk today really about championing technology for advancements for children and pediatricians. And for a long time, the Academy has really been at the forefront of championing what kids need. But it is my personal belief that we can't do that in a vacuum. And if we don't figure out how to champion what we need as colleagues and pediatricians, then we are not optimizing how we can care for the patients that we're privileged to serve. So my disclosures are that I have ownership shares in an electronic health record company, and the learning objectives are one that you can read. I'm hoping that you start to adopt and think about the information, the language of child first approach. And we're going to spend a little bit time talking about this. And my biggest hope is that you leave here thinking and questioning and being curious. I would rather have you think deeply than learn something new, because I think we have a huge potential with what is happening both in innovation and healthcare delivery to make a difference. So I think it's important for you to understand where I'm coming from and what my frame is. At the first, I'm a general pediatrician. I trained at Temple University. I went to St. Christopher's for my residency, and I was chief resident the year a hospital moved. Don't ever volunteer to or help move a hospital. I'm just going to tell you, especially when the bean counters decide July 1st is the right time to move a hospital. I still have PTSD about that, but I'm a general pediatrician. I expected to go practice in a small community and serve a community of children and families. But apparently that wasn't exactly where I ended up. And for those of you who are early in your career and you think you know what you want to do, please be open to be curious, because where you end up is unlikely where you think you're going to end up, and be open to wherever the world and opportunities to take you. I'm an entrepreneur in part because I question everything. My generation in elementary school was question authority. We asked everything like why, who thought this was a good idea. And you'll hear me say to people, what problem are we trying to solve here? And so when things didn't turn out the way I expected them to, my general pediatric practice that I joined out of my chief residency year in Bucks County, Pennsylvania, I was the fourth doctor and the only woman in the group. Worked there for a long time, for over a decade, and they sold that practice to a health system that was not pediatric focused. It was a health system that really knew nothing about how child health care delivery works. And I kept saying to my partners, like, we're smarter than them. They don't understand the problems that we're trying to solve. And it was also in the area where half of my patients were capitated, back when US healthcare dominated the Philadelphia market, and half of them were fee for service. So you quickly have to figure out, how do you have a business model that works, that you get paid to see half the people and lose money to see the other half of the people? And so you really start to think differently about healthcare delivery. So I went out on my own and opened up a solo practice in 2004. Yes, crazy, but was the best thing I ever did. I ended up trying to figure out, okay, what problem am I trying to solve by going out on my own? And one of it was that I believed that that care delivery for kids should be family and child focused, and that we should really develop our healthcare infrastructure from their lens, not from our lens, because they often have different priorities and needs than we do. And so I just looked to try to recreate this and figured I'd use technology where it mattered, and made things easier and increased access, and people where they could add huge value. And so I think outside the box. In fact, I've been known to throw the box away. So if you're thinking about you're constraining and trying to solve a problem because of things that are already constrained around you, I encourage you to say, well, maybe is it time to reconsider that we're trying to solve a problem inside of a paradigm that no longer meets our needs. And I would say both technology and healthcare delivery is changing so fast that we have to be able to challenge the constraints that are put on us around us in order to be able to serve the patients in an equitable way. I'm an accidental informaticist. I didn't train saying, oh, I want to go into clinical informatics, because it wasn't really a thing back then. I'm one of those grandfathered people. But what happened was, when I opened up my own practice, I said, okay, my husband's a technology guy. And I said, all right, I want to take the top 10 reasons people call their pediatrician and shouldn't have to, and make it self-serve. Can't you build me a website that could do this? And he's like, oh, probably. So starting with problem solving first, instead of trying to figure out how to build something cool and then sell it to somebody else, has always been my lens. And what happened was, he built me basically a patient portal in 2004, before it was called the patient portal, because I didn't want to hire a front desk to misspell somebody else's name on a computer. I didn't want to keep having to have people call up and say, I'm registering for kindergarten, can you give me my vaccine records? People lose their appointment cards and couldn't remember when their appointment was. All of those things I wanted to automate and make it happen. And so when I realized the technology tools were not out there to solve what I wanted to solve, I started knocking on doors and talking to people. And you quickly realize that if you find willing people to listen, and when you don't, I sometimes just bring my folding chair and stick it in the front of the table so they can't ignore me. But you'll realize that as child health experts, they don't really have the expertise that you do. We undersell our value to the technology universe because we have expertise and we can see things from different lenses than the people building the tools that we're often forced to use. And so I ended up realizing that I was in many ways the translator of what clinicians need to the tech builders. And then I had to go back to my colleagues and say, no, you don't want that button here. Tell me what you're trying to do. What problem are you trying to solve? Well, I want to see all of the, okay, that's what you're trying to do. And tell me how to fix it, because then I can go back to the developers and say, hey, let's think outside the box. So in order to be able to really advance that, I went back and did some additional training and got boarded in clinical informatics. And so I spent a lot of my career actually as the medical director for a pediatric EHR company. But most importantly, I'm a fierce fighter. We talked about this at dinner. Some of us went to dinner last night, because I think that we need to be bold for kids and pediatricians. We have an opportunity here to really move the needle, but it's going to take us to be bold and to speak up. And many pediatricians often feel like they don't have a voice. I would caution you to just remember, just like the kids that we serve, sometimes you have to speak out because it's the right thing to do, even if you're uncomfortable doing it. And it's okay to speak out and be wrong. And I like to go places. So for those of you who are thinking of things you want to ask me, challenge me, because when you challenge somebody, I think you always learn something new and you end up with a better result that serves more people. If you can come to a conversation where instead of us all nodding our heads, you actually challenge each other. Okay. So I want to start by framing who kids are that we take care of. And you clearly see this in your geography, in your neck of the woods, in your area. Kids are clearly highly diverse. They're a declining portion of the population, which is important, and we'll talk about that a little bit. There is huge geographic variability of where the kids are and where the people who serve them are. And there is interconnections of all kinds of other factors that are not just health focused, but we understand impact the health of children and families. So if you've ever been to Itasca, the AP home, there's this great wall where it says kids are a third of the population, but 100% of the future. Well, I'm here to tell you the kids are still 100% of the future, but they're 22% of the population. Now, that should give you pause. And here's how I'm thinking of framing this. We all know that pediatricians are underpaid and under-resourced and underappreciated in the healthcare delivery system. But if we start thinking about this, of economies of all of our states across the country, regardless of where you live, if we don't have a workforce, and this isn't all just fighting for our own pediatric workforce and training workforce and nursing workforce, this is like every industry. We do not have a healthy workforce that is going to be here to be able to support any economy in any state, in any sector of the universe. And if you read the NASM recent report, which it brought to stark reality that 78% of young adults who apply to the military are deemed not fit to serve. None of the three branches of government have met their quota for the last several years in incoming. So when we talk about child health and the declining child population, and I will tell you that if you remove immigrants from that 22%, it's in the teens. We have to really think and change the way we talk to decision makers and policymakers about what we need to invest in the infrastructure of tomorrow's workforce for our economies, which I think carries a different weighted message to people who normally just want to ignore child health. So please, if you don't forget it, if you don't remember anything that I said today, 22% of the population and declining. And I'm sad to say that my 31-year-old, my youngest kid, doesn't think he wants to bring children into this world, which is really sad for me as a pediatrician, but I completely understand where he's coming from. So where do kids live? Increasingly in the places where the pediatricians are not. So we have to think about our own role in increasing pediatric training. Residents stay where they train. Are we training for the kids that need and families that need our own workforce 10 years from now? I would argue not, but we all want to sort of figure out how to solve our own local problems. I think somebody's got to be paying attention what's happening in the national landscape. And so that's the population declining, and you can see where California is this, and you can see where Texas is. Anybody volunteer to move to Texas? I live in an island off the coast of Florida, so I understand. But a lot of the training programs are in the Northeast. That's not where there's more kids. What is our responsibility as leaders and trainers of tomorrow's pediatricians to speak up and do something about this? Or do we create an environment where people are willing to move and serve those communities and it makes sense to do so? Race and ethnicity of our population, and this is all from the government census data, and you can see the the links in the slides when you get them. But we know we are becoming more and more diverse, which is going to change how we have to serve our patients and the populations of our communities. And then there's the poverty statistics. Poverty is still a huge problem for kids, and it does not equitably impact all of our communities. And children of color are still significantly more impacted by poverty than the rest of the world. So here's an interesting graph. And if you think about it, I was born in '60, so I'm in that trough. And a lot of our political decision makers were also sort of my generation. And if you think about it, they were brought up in a part of time in our country where there were not very many immigrants in our country. That was not true historically before that time, and it certainly is not true today and tomorrow. Now, I have no solutions on how we solve this problem, and we see it every day. And the AAP is pro-child and pro-family, but not partisan. But we have to face the reality we have in front of us. And those of us who care for those families really need to have a voice at the table. And that's one of those places that you should take your folding chair and invite yourself to the conversation. So we know what happened with Medicaid unwinding after the COVID pandemic. And it's interesting because when they first started talking about this, I said, oh, the unraveling. And the federal affairs folks at the Academy said no, it's the unwinding. I'm like, no. It'll be the unraveling. You're just not sure that it's happening that way. Well, it's completely unraveled. And we know that, again, this is not universally impacting kids across the country, but there is clearly a cliff. We don't have data yet at the Academy of what happened to these kids. People who like to kid themselves and think there's a happy path think that all these kids want employer-sponsored plans or ACA plans. I'm telling you that many of them are uninsured, and we have not yet seen them in extremis, except in emergency rooms sporadically. Look at what's happened and how this is disparately impacting a few states. It is stark reality. I spoke at the Texas Pediatric Society, and I can tell you your colleagues there would like some hugs and some love because they are living this every day. Think about if this happened in your practice. Some practices literally had to close because a third of their population all of a sudden fell off the cliff, which then has economic impacts to the nursing staff and the MAs and the front desk and the access for those kids who remained. It just became unsustainable. And those are the percentage of states, kids who are enrolled in Medicaid and CHIP. You can see that's also not equitably distributed across the country. And there are some places where it's more than 50%, but the average is 50%. The other thing I'd encourage you to do is, if you see family over the holidays that are upcoming, ask them 2 questions, both your medical and non-medical and maybe adult medical friends. Ask them what percentage of kids are covered by Medicaid and CHIP in this country. I will tell you, nobody but pediatricians knows it's 50% or more. 50% of kids in this country are covered by governmental payers. And then ask them if Medicare, which covers seniors and is a governmental program, pays $100 for a service. What do you think Medicaid, which covers pediatric Medicare, pays for that same service? And they think, well, it's a governmental payer, it's $100. And then I have to tell them, no, in some states it's $33. That's how much we undervalue kids and what we do. So who are we? This is encouraging to me. The race and ethnicity of AAP members is changing over time, and it's still not where it needs to be. We don't reflect the kids and families that we serve, but that is the reality of where we sit. And this is really also impactful when you start talking about how do we solve the immigration problem, which I start with, what problem are you talking about and what problem really are you trying to solve? But if you talk to pediatricians across the country, and this came from a Places study, which is a longitudinal study of pediatricians that the Academy has been supporting for over a decade, we have increasingly numbers of pediatricians who either were themselves born outside of the United States or are first-generation US-born pediatricians. We are increasingly starting to look like and understand the plight of the patients that we serve. which I think puts us uniquely positioned to be part of the conversation for solutions. Okay. Anybody here have to deal with some debt in their medical school training? And anybody here had to make hard decisions about, do I still want to be a pediatrician? I will tell you that I meet medical students all the time, and even pre-medical students and kids applying to medical school who are making hard decisions about the inability to pay off their loans when, if they choose this as a profession. It's hard, but I'm going to also tell you it's not completely new. It's worsening. We were at dinner last night. We were talking about I trained in the 80s, and I paid for all my medical school training myself. My parents said, we have 3 kids. Here's the money each of you get for secondary education. The rest is on you, which I'm up to the challenge. But our health education assistance loans floated with the Treasury rate, which was in 17% at one time. In 1989, when I finished chief residency, I was $196,000 in debt, and my first job paid me $38,000. The math doesn't work. It's how I got involved in understanding the business of healthcare delivery, because I had no choice. I had to figure out how you make enough money to be able to pay off your educational debts. But we should not be saddling the people who are investing in that 100% of the future with enormous debts that they can't pay off. This is a FAP to children's ratio, and this is actually on the American Board of Pediatrics website, and there's fascinating ways to slice and dice this data, including specialists or just general peds. But again, you're seeing where we have concentrations of pediatricians, which are not necessarily where the concentrations of the kids are. And I want us to think about what that means if we're going to have equitable access for every kid in this country. Anybody not stressed? Yeah, so the Places also really talks to, over the course of the career of pediatricians, how stressed out they're feeling. And it's increasingly worse, and we know that the pandemic actually made that significantly worse. It used to be we were the happiest babies on the block, as you would say, except for pulmonologists, which I want to know what kind of inhalers they were using. But pulmonologists apparently were very happy pre-pandemic. Who wants to venture a guess how far we fell after COVID? The pulmonologists fell further than we did, just saying. But that's not our love of caring for kids somehow is what's, I think, directly connected to what is our colleagues are feeling every day when they walk into the exam room, and they're feeling like they just don't have the resources to do what the kids need and how to take care of them. And we really, really need to pay attention to that. I also think it impacts our ability to attract the best and brightest and a diverse workforce to pediatrics. If you think about it, most of us ended up in pediatrics, or at least solidified our interest when we were visiting somewhere and some kid gave you a chocolate hug or asked you some crazy question or threw up on your shoes or something, but you had a great day at work. And if you look at the match data, and I'm going to be anxiously awaiting what happens this spring, I think that was an acute problem on top of a chronic problem. Some of it's related to payment, but not all of it. Last year's match data, those students trained during COVID, what was the pediatric clerkship in medical school experience during COVID? Non-existent. They didn't get that opportunity to have hugs and flowers and kids look at them in awe and really look at that. So I'm hoping that this year will be different, but I'm a catastrophist, so I'm assuming it's not going to be. And we're going to have to figure that out. And how do we figure that out? And I think some of it really comes down to we have to be paid appropriately for everything that we do. This is where we live, in my opinion, right now in the world of pediatric payment. We're all fighting over a buck, right? Whether it's the children's hospital or the multi-specialty hospital or the primary care doctor out in the community or a federally qualified health center, we're all playing with change in the couch and trying to share the same dollar. And I think it's time to really stop and reframe how we think about investing in the economic infrastructure of the health of children instead of just talking about paying for healthcare delivery, because it's different. Insurance, if you think about it, car insurance, hurricane insurance, health insurance was not ever designed to invest in the health of a population. It was designed to take those catastrophic illnesses and amortize risk over a large population. So some of the reason I think that we're beating our heads against the wall is we're trying to fit this into, again, a box where investing in child health doesn't belong. And so how do we reframe our thinking and the conversation about investing in child health? And should it be actually a part of the defense budget because the military can't fill their ranks? Should it be part of the employer sponsored economics of states to invest in their healthy workforce? I don't have any answers. I have a lot of questions, and hopefully you mull a lot of these over as you think about the days go forward. So many pediatricians don't know that Medicaid doesn't pay the same every place in the country. And this is a Medicaid to Medicare fee index. Now, there are nuances based on the health system and your ability to leverage what you get paid by Medicaid MCOs. But it's again, hugely different, hugely different. Should it matter where a kid lives, what kind of services they can get, and what kind of resources pediatricians can get to take care of them? I would argue not. And there are some moves the Academy has made in the last couple of years to make payment transparency about what the Medicaid MCOs are paying people and access more open, so it's not a black box and they can hide behind their metrics, which they don't have to disclose to anyone else. But again, if we're going to get to equitable outcomes for every child, we can't have this much disparity across the country. Okay, child health financing and payment. I think this is really champions, and if you find yourself on a plane across the country, the NASEM report is actually worth really taking time to consider. But we really have to think about how we finance the economics of healthcare delivery in a way that all pediatric clinical team members get enough resources that they need. We're all underpaid compared to adult medicine, and our adult colleagues do not know this. They think that the pediatric GI gets paid the same that a adult GI does. They don't, for several reasons, including 50% of kids are covered by Medicaid or CHIP. And when you start getting into pediatric specialty care, it's even higher numbers of those kids with chronic and catastrophic conditions. And then the whole RVU system was set up in a way that doesn't really value thinking, right? It values doing stuff quickly. Nursemaids' elbows, like, you know, pediatricians' cash cow. You get paid you get paid as much as it takes to counsel 4 suicidal teens. That's ridiculous. It's totally ridiculous, and it's upside down. But we have to be at the table to have the conversation. I'm leaving here to go to the AMA meeting after this, which will be interesting. But if you don't know the structure of the AMA, I can have a conversation with you at a different time. But we don't, there's one pediatrician voice really voting when every adult specialty has their own representation at the table. The pediatrician voice at the table in the AMA represents all of us, specialists, generalists, and pediatric surgeons. And so we don't have a voice. And actually the Academy history is that the founders of the AAP left the AMA because there was an Townsend-Shepard Act, was it? Yep. Which was to, there was an act in Congress to try and reduce child labor, so kids couldn't be forced into labor. And the AMA thought that was a bad idea because small businesses and community farms, et cetera, needed to have their kids working on their farms in order to make an economic model. And a bunch of pediatricians said, you have to be kidding me. And so that's where the Academy really was formed, when they realized that the rest of the House of Medicine was not so interested in promoting child health the way we were. So knowing that, framing that conversation, you realize some of the struggles that we have in advancing some of this work. Okay. So let's talk and now move to how do we start thinking child first? And I think if we thought child first about everything we designed, even adults would win. But we have to figure out how do we make this elevator pitch in a way that they'll meet it. If you think about a developmental trajectory, we inherently know that that 23-weeker in the NICU does not need remotely the same care or approach to technology or medicine or a team-based care that the toddler needs, that the 9-year-old needs, that the pre-adolescent, like we live with a whole developmental trajectory and never assume and built for the average pediatric patient. There is no such thing in our world. Our brain is always about life course and how things change, including who matters in the kid's life, their community in the context of everyone else. If we think about framing healthcare delivery that way, I think everybody wins. Because I don't care if you're a young medical student, you're in a state of life where you need to have different healthcare and community needs than the residents do. Then once you start a family, if you choose to do so in the middle of that, and then your middle career, and then your end of life, and you're trying to care for your parents and your family members. If we can convince people that this whole developmental trajectory life course model, where everybody wins, and I think that we have potential right now with developments in technology, so that if we build it with that in mind, instead of figuring out what the average adult patient looks like, we're going to build it in a much different framework, and I think everyone wins. We also have to do this in the context of caregivers and family. And that is true not only of kids, but everybody else. No person is an island. We live in a middle of how we solve problems, whether it's a sick kid and you're a mom going back to work or a dad going back to work, or you're being pulled because an elderly aging parent has a catastrophic illness or what have you. We all live in a community and a family model where that has significant impacts in their health, the way they receive healthcare delivery, and the outcomes of families. So we have to really stop thinking about the patient. We have to be thinking about everything around the patient. And I think community matters, and you guys know that. There are a lot of great community efforts out here. And so much of pediatrics is public health. And I would argue does not belong one person in an exam room at a time. We can't scale ourselves out of public health messaging. Public health people are the only people who get paid less than we do. We got allies here, but we have to figure out how do we get community messaging. Should it matter if you make it to your 9-month-old checkup, whether you get the messages about anticipatory guidance, or should it be in buses and daycares and public service announcements, and when you go pick up at the grocery store, your what have you? That this, to me, I think we're holding on to some pieces of things, that there are community messages that are much better able to have impact and in ways that are more culturally appropriate, using community health workers or other allies in the community to get those messages across. If you have not seen this before, this is really the difference between giving everybody the same thing and giving everybody what they need to really succeed. But I want us to look at our own house and think about how you deliver healthcare. We've all gotten into these clinical algorithms because it's the right thing to do to make sure that kids have the best outcomes, and the research shows it. But we haven't figured out how to do the science with the personalization. We have to figure out exactly what everybody needs. And some of the decisions we made are based on payment. I can tell you there's children's hospitals across the country who are making decisions. They're no longer doing telehealth. They're making every patient come in because they get a facility fee and they get paid better to do that. You tell me if you're an essential worker parent, single parent of 3 kids, and you have time and your kid can afford to miss school to be able to come to see you at a children's hospital between 9 and 5 Monday through Friday. That is not equity centered, and we have to really figure out how to give patients what they need. And I would tell you that if one of you your children were my patients and had asthma, if you were traveling and you said, hey, can I just run this past you, the kids asthma action plan? I should be able to just have a conversation with you to promote that child's health. And why should that be paid any differently than the kid who I need to see in my office, or the one I might be able to connect to via telehealth, the healthcare delivery should be customized to what the family needs, not how we get paid best to deliver it. So I don't know if any of you have seen any of the data about where we're going with tech and how it's made equity worse in many places. We know that health inequities, when we innovate, we tend to innovate for those people who already have digital literacy and good health literacy, and we're leaving the people who most need us further behind, saying that we're going to get to them on the next round. How many times have you seen that effort fall on the floor? Just like every time we're in conversations with programs in the government, one of them is the research that was supposed to be about every person. They were going to loop back with funding for kids the second round. Yeah, we all know what happened to that, right? So we have to really figure out how we make our technology start with that equitable center and build it from the beginning, not wait to add that on once we have a proof of concept that works for the average patient. Because what's happening is we're getting better and better access for those people who have more and leaving the people who are marginalized further behind. This is a great article, if you haven't had a chance to read it, really looking at health inequities and digital health technologies. And I would urge all of you who are being innovative, change your thinking in the proof of concept phase to where it starts, where you're thinking about health equity in the beginning, not at the end. All right, who feels like they're a hamster on a wheel or being torn in 27 directions, all of that stuff? Let's do more work, do it in multiple formats, do it faster, do it safely, make everybody happy. Anybody accomplishing that? Yeah, we're all just ready to jump off and, go find something else to do, right? Like maybe we'll be baristas at Starbucks. It seems a little bit more interesting right now. That is really what's being forced upon us, but we have to say stop. We have to be the people, and those of us who are decision makers saying best practices, we have to think about when you do studies in an academic institution and you have funding to do it, stop and think what you're asking then someone to do in Wyoming, where there's one pediatrician in 3 counties. We have to think outside of our own silos if we're going to keep asking people to do more innovative stuff. So this is Bright Futures in 1974 when the whole concept happened. Like, how are we going to give every kid a chance at a bright future? I could do that in 20 minutes. That's 2008. That's 2024. Guess what, people? We haven't gotten paid any differently to do that since 2008. The RVUs for pediatric well visits haven't changed. And in part, because we're afraid if we open it up, they'll take it away and make it worse. Now, I think it's time to be bold for kids, but we have to be willing to make the argument. And if you look at the healthcare financing piece of it and the economics, should we even be paying for well care with health insurance, or should we be funding it in a different way? But all of you who do studies and try to figure out just one more screening, one more survey, one more, like at what price? Anybody have families who are starting to refuse to do surveys because they're surveyed out? We have to think about that from everybody's lens, not just what we know. Maybe there's a different way to accomplish that without trying to put it one more thing on a well visit in the pediatric well visit. Okay, so anybody feeling this information? Let's just exchange more information, more places, more different ways, and get it all in front of you. So we couldn't get it to run, but I encourage you to click on the information overload when you get the slides. Anybody remember this screenshot from a movie? Anybody an airplane fan? Where the dashboard, the analog dashboard, just scrolls and scrolls? Anybody feel like that when you stand in front of your EHR? More and more information just coming at me in multiple, and it all looks the same, sort of like spreadsheets. I don't like spreadsheets. We have to figure out what we're doing here. And I actually think this is where technology can help us. We're getting multiple formats of the same data in multiple ways. And we quit sending me soap notes from consultants. I'd like the assessment and plan. I know why I send the patient to you. Like as a general pediatrician, that's something you all can fix if you haven't already done it in your system. Send people in a format the way that they can digest it, in a way that they can move it. And so what do we have? Overworked and under-resourced pediatric teams. So every time you're thinking about there's this new technology, start asking them, you got to figure out what else are we asking them to do that's not paid and adds one more implementation burden. And you have to just go to a different application or to your smartphone or your whatever. Can we all just put it in one place so we're not distracted and going into 40 different interfaces? Because what happens is we start to feel inadequate. And to me, that's the moral injury. We leave every day feeling like I was no good at using my electronic health record. I couldn't give the patients what they need. I couldn't connect them to the services they need. I can't get them a visit with their specialists. I can't get the medicine paid for without prior authorization. We leave every day just feeling like we're woefully inadequate. And to me, that's really what's hurting our souls. And we have to figure out how we get to a place where we know we're doing good for the kids and families that we serve every day when we walk home. So all of you innovation stakeholders, if you're pitching a good idea and everyone's nodding their head, you did not invite the right people to the conversation. So you have to figure out who are your staunchest advocates, but who are your staunchest critics, because you will learn something from them, and make sure that patients, families, and your whole team is at the table. It's not just your idea, but you have ideas of everybody, supporters and doubters, and don't figure out how you're going to pay for it after you build it. Figure out the economic, both who's paying for the technology, the healthcare delivery, and what it means in different settings, and if they're going to do it, right? We need everybody at the table, which means a lot of conversations, but I think it's well worth investing up front, because if you don't get it up front, you're going to spend a lot of time and money doing it on the other side. So what happens when we get resource constraints? Because that's what they always say, like, we don't have money to do that. We only have the money to do it, right? So you get insufficient viewpoints at the beginning. And then what happens is your proof of concept becomes the thing, right? It's like never where you planned to start, right? It was never where you planned to land, but it ends up, the minimal viable product becomes the product. And then I've watched developers do this all the time. They build to the happy path. And I'm the catastrophist who says, and what happens when it times out and it doesn't recover, or your internet goes down, or the blue screen of death hits everything across the country I was in an airport, that was interesting, when that happened with Change Healthcare. So then you end up prematurely at the market, and you don't build in the feedback mechanism. If we're going to build innovative systems, we have to build the feedback mechanism up front. Where are we going to get the data? Is it working for all the stakeholders? Does it apply to other populations? And I think the right answer to this is the power of collaboration, which is why I was most excited to come here, because I think there's huge opportunity between the academy and innovators like you guys across the country. I want to say that I did not realize when I took this position how much the AP grounds what we do in policy. Whether it's tech policy or payment policy or what have you. Yes, it takes forever to write a policy, but that means that the person sitting in the president's seat, it's not just what I care about. I don't have the expertise in all these things. I look to the subject matter experts. So ask number one, what's missing in AAP policy that you need to advance your work? Where do we go, and what kind of things do we need to advocate that we need policy to stand behind, to stand for kids and families in the tech world, in the medication delivery world, in the healthcare delivery world? What's missing? And because we look to you as the subject matter experts to happen, and then we can have the power of advocacy together. One of the things that happened was the Center of Excellence at the Academy for Social Media and Adolescent Mental Health, and it's incredible. And then the strength of education. If you haven't seen the AI offerings that the Council on Clinical IT has done, they're fabulous. So in an ideal world, I think technology would be designed child first, equity focused, feel personalized. We can use technology to do a lot of the background stuff and wrap things around it that feel personalized, which we've not been able to do. We have to figure out how we begin with the whole and then have meaningful conversations. And I think that makes a better healthcare delivery for every kid, and every pediatrician gets the resources they need to serve them. So happy to take some questions, and sorry if I talk too long.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.